post case especially, and I'm presenting our data about the various contact lenses and what was the patient satisfaction with these type of lenses. Well, I have no financial interest in any of the products I'll be mentioning in this presentation. Well, contact lenses is something like an old wine and new bottle. With the available lenses today, with a lot of variety of lenses that we have for keratoconus, and there are always a new lens coming in the market for keratoconus, and each one claims to be better than the other one. But however, these are all time tested and are actually the gold standard for improving not only the visual acuity but also the quality of vision in most of these patients with keratoconus. And in most of the cases, you get a good fit with most of these lenses. However, what you need a good protocol-based approach in order to have a good outcome in terms of the fit and also the final visual outcome in these patients. So what contact lenses do is they regularize the corneal topography. There are a variety of contact lenses that are available, starting from simple soft two-way contact lenses to custom soft two-way lenses to rigid permeable lenses, which are the hybrid lenses available, the Bose-K family of lenses, semi-scleral, and finally the scleral contact lenses. When you look at RGB lens fitting, this has been the gold standard. However, the most important thing to understand with this is you have to have an optimal lens that you have to fit in these patients. Even for RGB today, we have multiple materials that are available. Today, RGB lenses are also available with the Boston material, which are giving good comfort. But the most important thing to understand, as these lenses will take a little bit more of your chair time, you have to understand your first choice of lens will usually depend on your back optic zone or diameter, and you have to preferably go on the flattest keratometry value to fit an RGB lens. When you're trying to select the first lens, always start with a flat K. Go for the flattest K. More important, along with the K value, is to see where your cone is located. You have to understand the topography well. See that the cone is centrally located and an inferiorly dislocated cone. Depending on the zone in which your cone is located, take the flat K value of that particular zone and accordingly fit the lens. Again, this is important also to determine the diameter of the lens you want to choose. Most of the Indian cones are usually central and nipple cones, in which cases you require a smaller diameter lens and also you may require a steeper lens. Comparatively, if you are going for an inferior cone, you require a lens which is a larger diameter lens. An aspheric lens design, which is what nowadays we have, most of the lenses are available, they usually fit quite well and also give good comfort along with a good visual acuity in these patients. A good fit in these cases would depend on a satisfactory lens centration. Whenever you want to look at the lens centration, always look in the primary gaze and not when you're having the eye moving up or down. And also you have to look with the lids moving apart, and the lens should slowly drift downwards rather than having an extensive movement. And in the normal lid position, the lens periphery should not go beyond the limbus. It is only in these cases that a patient will complain of irritation, watering the eyes, and in the lenses that really have a lot of movement. Alignment, you have to also have a good dynamic fit, and you have to check the fluorescent pattern in most of these cases. Depending on the fluorescent pattern, you can actually change your fitting. When you are having a low cone, that is when your lens is low lighting, what you want to do is increase the diameter of the lens, or flatten the base curve, or increase the edge lift. Or a simpler option is to do a piggybacking with the contact lens. When you are doing a piggybacking, first you have to put in a soft contact lens, after which either you can do a topography again for the patient or go for almost completely flatter than what you would take for your otherwise RGB lens. For superior cones, which are either higher cones, what you would want to do is decrease the diameter of the lens, steepen the base and decrease the edge lift. For small, steep cones, you may have to flatten the base curve, decrease the diameter, and also sometimes increase the edge lift in order to have a good fit of these patients. For most of the cases with advanced cones with an apical touch, a smaller diameter lens is what is preferred because it will give steepness and also prevent any apical touch, and it leads to scarring of the apex. In early cones, you may be going for a large diameter lens which will give comfort and also have a good centration. For very astigmatic cornea, you may also have to resort to some kind of a toric lens where you have to change the peripheral edge lift and also do any sector management, which is not possible often with RGB lenses, but with other types of lenses, you can have a better fit with these. With this, in order to have a lot of patients who keep complaining they have broad irritation, and that's when you shift to other types of lenses. A new one in the market is custom soft two-way lenses for keratoconus, which comes by Kerasoft. These are soft two-way lenses which are multiple curves. They are usually silicone material. They come in various ranges of base curves starting with 7.4 up to 9.4 with a 0.2 inclinal image. The diameter is 14.5 millimeters, and you also can increase the diameter on 0.5 millimeter differences. The lens design is basically a front aspheric surface or aspheric toric surface which has prism ballast. This also has toric markings which have to be adjusted, and you have to the fitting is not similar to what you will be doing for a soft toric lens. It's very different. You have to start go in for a protocol which is based on the lens parameters. First, you look at the topography, whether the lens your cone is small, central. In that case, what you will want to do in an early case is that you go for a little steeper base curve, that is around 7.4 or 7.6. And you can also have the periphery, which can be changed from a standard to a flat or a steeper periphery, and also you can do a sector management in cases when you are having decentered cones. Whenever you are having a cone which is inferior to decentered, you will have to go into a sector management. In this case, you can actually modify two sectors of the lens area, where you can actually flatten a particular area in order to have a good fluorescing pattern in these cases. An optical lens fit with a Kirasoff lens would have a movement which is not more than 2 millimeters. The lens marks, that is the laser marks, would be vertical. They would not be rotating easily. The lens would center on the cornea, and it would not really move a lot with the movements of the eye. Patient would be comfortable, and most important, the visual acuity has to be stable. There should be no change or fluctuation in the visual acuity along with any blinking of the eye. So in order to fit these lenses, what you follow is called a monochrome principle, where you look at the movement of the lens, the rotation of the lens, vertical lens marks. You have to look whether the lens is centered or it is getting decentered on the cornea, whether the patient is comfortable or the patient is getting uncomfortable after some time, or most importantly, the visual acuity has to be stable with every length of the patient. Changing from these lenses, the disadvantage I see with Kirasoff lenses is that most of these lenses over a period of 6 months start getting discolored, and the patient loses a visual acuity that he had initially with these lenses. These lenses fit very well in PMCD because you can actually play with the peripheries. You can actually have a good sector management with these lenses. In my practice, they go in only as a step when patient wants to discontinue his RGP lenses and doesn't want to go in for a scleral lens or any other type of lens. And on early PMCDs, I'm going for this particular lens. A better way of fitting these patients who are not comfortable with an RGP lens is to go for a hybrid lens. These are usually an optimized lacrimal lens, which is just having a central RGP lens with a peripheral soft skirt which is made of certain material. Advantage is that it gives an optic that is centered over the visual axis, and which, irrespective of the collocation of the cone, would always give a good visual acuity. It basically is depending on the wall. You often would not even require a topography in order to fit this particular lens. What you really have to choose is vaulting. You would not have to really touch the cornea, and you would just be getting a small central apical touch along with similar to rose cavity, a 3-point touch. The rigid component is 8.4 millimeter, and the oxygen permeability is quite high with these lenses. And the soft skirt almost extends to 14.5 millimeter, making these lenses really fit into almost every type of cone, starting from an early keratoconus to even the most advanced keratoconus, depending on the vaulting. So these employ a continuous aspheric base curve from the lens center to the periphery of the lens, and they are available in various types of base curves, and also their walls can be changed. The most important thing is that the rigid optics in the central part really provide you an optical visual acuity compared to a Kirasoff lens, which being a soft lens will not provide as good visual acuity as with any hard lenses. But other advantages, the soft skirt improves the comfort of these lenses and also increase the stability of the lens over the period of time, and you give a good hydrophilic non-ionic soft skirt, which also decreases the irritation in most of these cases. Again, these lenses are quite stable rotationally, and they really do not change position or movement with the eye blinking. So when you compare these with RGP lenses, in cases where you are having decentered cones, most of these RGP lenses would be drifting down, and the optics would not be centered and would cause more visual disturbances to these patients. Looking at these kind of hybrid lenses, these lenses always would center to your visual axis and provide very good visual acuity. An ideal lens fit with a clear cone lens would have an apical clearance. The outer and the inner landing zone would show, inner landing zone will be showing some bearing, some thinning, and the outer landing zone will be having some bearing of the fluorescein. Whenever you want to start fitting these lenses, from the transit, the first lens will be a medium skirt 250 micron wall. You have to look at the fluorescein. Once you have inserted the lens, you have to see the fluorescein within the first 3 minutes. After which the fluorescein pattern keeps changing over a period of time. And you will be looking at whether there is any central bearing that is seen. In case you see a central bearing, you will want to increase it by 100 microns until you start getting an apical clearance. Once you get an apical clearance, you start determining and just decrease the wall a little bit till you start getting a perfect fit for these patients. With a proper fit, you have to first determine the central fit, then start looking at the peripheral fit on the landing areas. So you have to check at the 3 o'clock and the 9 o'clock position, that is a horizontal landing area, where you are having the inner landing area thinning and the outer landing area bearing has to be seen. Based on these, you would really want to get an optimal fit for these patients. The most important thing is that the care of these lenses is extremely important. You have to have a proper multi-purpose solution, preferably an optic replenish from Alcon. And these lenses are again a 6-monthly disposable lenses which has to be really told to the patients. There's a lot of patients who wear them over 2 years, 3 years and they come with irritations in their eyes. And a good over-refraction is what is important. Most important thing for these lenses, irrespective of the wall that you have, your over-refraction has to be same with each and every lens. So it should not change with increasing or decreasing the wall. So when you really look at the So when you look at the patient, the movement is absolutely minimal with these particular lenses. And based on the fluorescein pattern, we will be just seeing a small central area bearing. Your inner landing zone will be showing thinning along with bearing of the outer landing zone. The patient comfort is extremely important. Quite often when you are having a tight lens, the patient will be uncomfortable and will not be tolerating lens for more than half an hour. Coming on to the Rosquet family of lenses.
I would request you to hurry up and finish your presentation.
So now the Rosquet family of lenses has come with 5 types of lenses along with the standard 4 types, that is the Rosquet 2, the Rosquet nipple cone, the Rosquet irregular cornea, the postgraph, and the new variety being the Rosquet XL variety. They follow a very standard and simple to fit principle of fitting in these cases. So based on the fluorescein pattern, you can actually go in for a good 3-point touch in these cases and have a good comfortable fit in the first or the second trial lens itself. So when you just looking at this fit, it shows a good standard 3-point touch with a good movement of the lens. And you also see that the visual acuity improves in most of these cases instantly in these patients. The comfort is extremely good with these type of lenses. For very advanced cases that you cannot fit with any of these lenses, what you would have is to give them scleral contact lenses. These are also known as haptic lenses. They are basically a fluid reservoir lens which regularizes your topography instantly in most of these cases, even for the most advanced cases. They come ranging from 15 millimeters to 23 millimeters, 15 to 18 being the semi-scleral lenses and 18 millimeters above being the scleral contact lenses. And also these depend on the vaulting on the cornea. At any point of time, the vault has to be clearing almost 100 microns from the cornea. And what you do is to fit these lenses is to go for a vault reduction method. For most of these keratoconus patients, you start with a 52 vault, start looking at the fluorescein pattern, and you would want to decrease the vault, and you just see a small touch in these cases. So you can actually fit in most of these patients, even with the patients who are having worse of this kind of scarring, like this patient who had got a central scarring. This is a patient I had seen with Vishram, and Vishram referred for contact lenses. And surprisingly, even despite this scarring, This patient with a contact lens had a vision of 624. So our experiences when we looked at various contact lenses for visual rehabilitation of keratoconus and irregular cornea, we tried to compare in terms of the ease of fit, time required to achieve a perfect fit, the patient comfort and the best final visual acuity with different type of lenses. We looked at the Rose family of lenses, RGP, Kerasoft, hybrid lenses, semi-scleral and scleral lenses in terms of these parameters. What we found is that in a 3 months period where we had seen patients with irregular cornea, 74 of these patients had undergone contact lens fit, and based on the protocol, depending on the type of topography, a particular lens was chosen, and we found that when we looked at the number of trials that were required in order to have an optimal fit of the lens was highest with the RGP lenses. In cases of Rose, in the second or third trial itself, you get the most optimal fit of the lens. And when you look at the patient comfort, when we scale them from 0 to 5, with 0 to being the most uncomfortable and 5 being the best comfort, the Rose family of lenses and the Kerasoft and the clear cone fell into the grade 4. That is, the patient was most comfortable with the lenses, and then the most uncomfortable ones were the RGP lenses. And also the time required to train these patients to wear contact lenses was highest with clear contact lenses and hybrid lenses. So Rose and hybrid lenses provide good comfortable fit to most of these patients with irregular cornea. Semi-scleral and scleral would be reserved for the advanced cases. The chair time that is required for fitting is least with Rose family of lenses and highest with scleral contact lenses. So these should be reserved only for your cases which are having extreme ectasias. Thank you.